So this will be the part 2 of the INIPYQ 2020 session. Yesterday we did the part 1, so let's start the part 2. Here we have a patient who is a chronic smoker, 50-year-old, presenting to us with hemoptysis but no fever or weight loss. The important findings are patient is elderly, smoker, there is hemoptysis but there is no fever or weight loss. X-ray is normal and sputum is negative for AFB. So this is not tuberculosis. And the most important is this is less likely tuberculosis because at this age with the smoker and hemoptysis malignancy is more than TB. Fever, the important features of that go in the favor of TB are fever, which is usually associated with night sweats. There is cough and there is weight loss. So if all of these are usually negative, then it is less likely to be a TB and more likely with this age and smoker, more likely malignancy. Then next, you should remember that what is the most useful diagnostic investigation. No doubt it is always CT. Lung malignancy investigation of choice is always contrast CT, except in one case, which is Pancoast tumor. It is the only thing that I want you to know in the lung malignancies, that Pancoast tumor is the superior sulcus tumor, that it arises from the apex of the lung. It is a non-small cell cancer of the lung. Then it involves the brachial plexus and so the Horner syndrome, and investigation of choice in this case is MRI because it is involving the nerves. So the 5 points about Pancoast tumor: it arises from the apex of the lungs, that's why it is called as the superior sulcus tumor. It is a non-small cell lung cancer. It involves the brachial plexus. Horner syndrome is associated feature, and the investigation of choice is MRI. Then coming to the next question, that higher risk for patient developing with the TIA developing stroke in the future according to the ABCD scoring. We should know that the ABCD scoring is used for predicting the stroke in TIA. So ABCD scoring is for predicting the risk of stroke in TIA. So the factors are age more than 60, systolic BP more than 140, and DBP is more than 90. The most important point to note here is this: it is either SBP or DBP. It is never both. So you can see in this option there is and. So this is the SBP more than 140 and DBP. This is not the case because DBP should be more than 90 or SBP more than 140. Then clinical symptoms may unilateral weakness, speech disturbances but there is no weakness, then duration more than 60 minutes or 10 to 15 minutes, and diabetes. So all of them are given one score except for the two, that is when there is weakness and when the duration is more than 60 minutes. So age less than 60 years, this is not in the criteria. Duration of TIA more than 5 minutes, no, it has to be more than 10 minutes. 10 to 15 minutes is 1 and more than 60 minutes is 2. So the answer is diabetes here. Another point that I want you to know is the 3-month rate of stroke. When the ABCD score increases or when it is more than 4, then there is a rapid rise in the risk of the stroke. This is important. Till 3 there is a very less chance of stroke in the next month, but after when the score is more than equal to 4, then the risk increases drastically. So that's all you need to know about. This score is very important for the exam. The next question is the serum electrolyte value of a patient weighing 60 kg. Okay. Then the sodium is 120. That's all we need. So to calculate we have to calculate the sodium deficit. The sodium deficit, to calculate the sodium deficit, the formula for sodium deficit is it is 0.6 into body weight into target sodium minus patient's sodium. So it will be 0.6 into body weight of the patient is 60 Target we will take around 140. Usually you should take 140. Patient sodium is 120. So this will come out to be 720. That is the answer. So this formula is important for you. You should remember this formula. This question has come many times in the exam. So this is very important. Then coming to the next question. Now this is another important question, the treatment of the NSTEMI. So you should learn the difference, you should know the difference between STEMI and non-STEMI. STEMI is the total occlusion of a single artery, whereas NSTEMI is the critical occlusion of multiple arteries. It is not total. This is the most important. Then next thing is STEMI is because of the red thrombus, which is fibrin rich. That is why thrombolysis or PCI works. In this case, thrombolysis is by the fibrinolytics like streptokinase, whereas NSTEMI is by the white thrombus, which is rich in platelets. That is why antiplatelets work in this case, and in NSTEMI there is no role of thrombolysis. There is role of PCI in the latest guidelines. PCI has to be done in both the NSTEMI as well as STEMI, but thrombolysis has no role in NSTEMI. This is very important. So in this case question, what is the except? So the answer will be streptokinase. We will give the aspirin, we will give the clopidogrel, we will give the prasugrel. All of these are antiplatelet agents. So they all of course have a value, but streptokinase has no value in the STEMI patients. Then coming to the next question, this was the same question repeated in the same exam. Similar question, 3 hours of chest pain, ECG में ST depression and T-wave inversions. So this is nothing but again they are telling about NSTEMI. You should know one thing, that STEMI is ST elevation, we all know it. NSTEMI can be T inversions or ST depressions. Both of them represent NSTEMI. So how you will manage it? There is role of PCI, yes, but the best answer is aspirin and heparin. We have to give the aspirin and heparin. This is the drug of choice or the best treatment in this case of NSTEMI. Thrombolysis has no role. There is no point in giving prophylaxis of arrhythmia. Whenever the arrhythmia occurs, we give the treatment for arrhythmia. Arrhythmia is not something that we will give prophylaxis. Then coming to the next question, now this is a very important question. Here there are few definitions of the hypertension that you should know. First, hypertension itself. Hypertension is defined according to the ACC-HC. It is BP more than 130/80. You should follow this, and GNC according to is more than 140/90. Then there is next term, hypertensive crisis, which is when BP is more than 180 or more than 120. When the systolic is more than equal to 180 and diastolic more than equal to 120. Now this hypertensive crisis is further divided into two things, that is hypertensive emergency and urgency. Emergency is when there is target end organ damage. Hypertensive when there is no end organ damage. End organ damage can be encephalopathy. So what are the target organ damage that are possible? It can be encephalopathy. It can be pulmonary edema. It can be blurring of vision. It can be renal failure or AKI or renal failure. So these are the target organ damage that you should keep in mind. So when there is no target organ damage, then it is hypertensive urgency. If there is damage, then it is emergency. Another important point that they can ask here is, in hypertensive emergency, the treatment is IV labetalol, whereas without target organ damage, we can give the oral drugs for the treatment. This is very important. Hypertensive emergency, we must treat the patient with IV drugs, and in urgency, we can give the oral drugs. Then there are two more terms, which is accelerated hypertension and malignant hypertension. Accelerated is when there is hypertension with retinal hemorrhages or exudates. When accelerated hypertension is associated with papilledema, this is important, then it is malignant. This is very important. This is very confusing. Accelerated is hypertension with retinal hemorrhage or exudate, there is no mention of BP. Of course, it will be more than 140, 90, 130, 80 से ऊपर ही होगा BP. Then, if it is associated with retinal hemorrhage or exudate, then accidental hypertension. If it is associated with papilledema, then it is malignant hypertension. The next term is resistant hypertension, which is our question. The BP of more than 130 by 80 or more than 140 by 80. Oh, sorry, more than 140 by 90. Any of the following can be both the guidelines. There are different guidelines for this. So according to despite 3 or more antihypertension and hypertensives, one must be diuretic among them. This is very important ki there should be one patient should be on one diuretic. So when a hypertensive patient comes, we will start the patient on ACE inhibitors, ARB, calcium channel blocker. So until unless you add a diuretic and patient is not controlling on those 3 drugs, you cannot say it resistant hypertension. So the answer will be D, that is BP more than 140 by 90 with 3 or more antihypertensives. Coming to the next question, components of MELD 2016 score. So first of all, the MELD score is used for prognosis in cirrhotic patients. Then MELD 2016 score, it is an old score. Currently we are following the MELD 3.0 score or MELD sodium score. These are interchangeable terms, and the mnemonic for it is F basic, where the components are female, bilirubin, albumin, C sodium levels, INR, creatinine. You don't need to know the value, you just need to know that these are the components: female, bilirubin, albumin, sodium, INR, creat. That's it. Now in the score of 2016, albumin was not the part. So in 2016 MELD albumin, until unless they are not mentioning about the MELD 2016, this is an old question. So currently they will ask you about the MELD 3.0 MELD NA, in which albumin is a part. But in the old question, in the old score, albumin was not the part. Now coming to the next question. This is a simple question. Graves' disease, patient in her pregnancy. The baby was born with aplasia cutis congenita. So which drug could have caused? This is a known side effect of carbimazole. That is why carbimazole is avoided in the first trimester, and first trimester mein drug of choice is propylthiouracil, and in second third trimester the carbimazole is the drug of choice. Why PTO is not if we are giving PTO in the first trimester, why we are not continuing it in the next second and third trimester? Because PTO has long term use of PTO causes hepatotoxicity. This is the most important side effect of PTO, hepatotoxicity. That is why we are not continuing, and we will shift the patient to the carbimazole when patient enters the second trimester. Coming to the next question, patient with the complaints of chest pain, best investigation to diagnose MI within 2 to 4 hours. So this is simple question. Within 2 to 4 hours, the best investigation is always TROP I. Now if the option had TROP I, then it would have been much better answer than TROP T. So TROP I or TROP T, these are the most specific and the best test. It rises within 1 to 4 hours. There is one more important, that recently HS TROP I is the newest test, which rises even within 30 minutes. Highly sensitive TROP I. And TROP I is also used for a marker of reinfarction. And there are 2 terms that you should know, that if the MI is occurring within 28 days of previous MI, then it is reinfarction. Marker for reinfarction is TROP I itself. If the reinfarction is occurring after 28, then it is 28 days, then it is recurrent MI. So these are the important points that you should know about the TROP I. That is, it is the best test. It rises within 1 to 4 hours, even 30 minutes, the highly sensitive TROP I. It is the marker of reinfarction. Then coming to the other markers, that is the LDH. Normally we should know LDH2 is more than LDH1. In MI, LDH1 is more than LDH2. This is known as the flipping of the LDH. That's it. LDH1 is more than LDH2 in MI. We can remember it by this MI, this one and this one. So just a simple mnemonic ki MI ends with I, so LDH1 is increased in MI. Then coming to the myoglobin, Myoglobin is the earliest to rise, but we cannot. But it is not a measurable marker. We don't have any methods currently, but it is the marker which is earliest to rise. Theoretically, it is the earliest to rise. Whereas there is the new marker, this is the fatty acid binding protein, hard fatty acid binding protein. This is the best overall best marker. It is in the research phases. So for your exam, TROPA is the best marker. The flipping of the LDH is most important. Myoglobin is earliest to rise, and best overall is heart failure fatty acid binding fatty acid binding protein. Then the next question is patients with palpitation, coming with palpitation, pulse rate is 180 per minute, BP is 70, narrow QRS complex tachycardia with regular heart rate. So for at your level, narrow QRS complex tachycardia with regular heart rate is PSVT. At your level, you just have to just rectify this, that narrow QRS complex tachycardia with regular heart rate is PSVT. Next step in management. If the patient is hemodynamically unstable means patient is in shock, patient is altered sensorium. Any kind of this condition, the treatment is always DC cardioversion, no doubt. Any arrhythmia, patient in shock, this is the golden line. Any arrhythmia whatsoever with shock, treatment is shock, DC shock. That is the treatment. That's it. No doubt in it. Now coming to if the patient is stable, then the first step is always carotid massage or the Valsalva maneuver. If it fails, if the rhythm does not revert back, then we will go with the IV adenosine, which is the drug of choice for PSVT. This is the drug of choice for PSVT. And the dosage is, you should know this dose, this can be asked. We will give the 6 mg. Then if it is not revert, we will give 6 mg again, then 12 mg. This is the maximum dose you will give of dose of adenosine we give. Then if this also fails, then there are two options. We can give IV ibutylide plus AV blockers or IV procainamide plus AV blockers. AV blockers, you should know the mnemonic, the BCD, B for beta blockers, C for calcium channel blockers. Calcium channel blockers be non-dihydropyridine. What are non-dihydropyridine? The verapamil and diltiazem. Then lastly, D for digoxin. So this is important for PSVT. Patient is hemodynamically unstable. Any arrhythmia with hemodynamic instability, you will go with the DC shock. Stable hai PSVT, then you will go with carotid massage and Valsalva. Then if it fails, then the drug of choice is adenosine. If it fails, then the ibutylide. If you have to choose one option among ibutylide or procainamide, you go with ibutylide. Ibutylide is much better than procainamide. Ibutylide is the second drug of choice in PSVT patients. That's it for the today. Thank you. Revise these 10.